Hello, everyone. I'm Jack Cushwood, Room Now, and welcome to the EULAR 2022 Daily Recap. It's day 2, and I'm joined by faculty and friends, Dr. Robert Chow, Dr. Richard Conway. We'll let everybody introduce themselves. I'm Jack Cushwood, Room Now. Robert?
Yeah, I'm Robert Chow. I'm a rheumatologist over in Northern Virginia.
And Richard?
And I'm Richard Conway, rheumatologist in Dublin, Ireland.
Okay, as we did last night, we have people from all over the world looking at EULAR 2022, such as the nature of meetings these days. A second full day. Yesterday was sort of a busy half day, and this was a full day of meetings. The profile always seems to be a little bit different. The morning was rich in abstract scientific presentations, mainly abstracts, oral and poster presentations, and in the afternoon had a lot of seminars, that we could learn from and whatnot. So again, I'm going to ask everyone to throw up what they liked the most today. And it could have been a seminar, it could have been a poster. Let's start with Dr. Chow.
Yeah, thanks. I thought today, focused a lot on a lot of safety data. And some of the things that I find myself very cautious and very apprehensive about is two topics. One is pregnancy and the other is cancer. So a few studies today. The first one is a oral presentation, 138. It's a large study from Spain looking at biologic and targeted synthetic DMARD use in our patients with a prior history of cancer. They actually had a large database of over 9,000 patients, 300 of which, 352 had a prior cancer history. And they did find that overall there's an incidence of 32 malignancies, mostly solid cancers, solid tumor cancers, non-melanoma skin cancers, one incidence of melanoma. The overall incidence rate was about 27 events per 1,000 patient years. Notably, I think kind of on par with what we are already expecting. IL-17 inhibitors had no events, but also keep in mind it was also the least amount of patients in that cohort, and second followed closely by CD20 inhibitors. And then the highest actually was in the CTLA-4 group. But overall, they did not find a significant difference in the rate of incidence of cancers amongst JAK inhibitors, CD20s, IL-6s, CTLA-4s versus the TNF inhibitor group. So I think some comforting data, but if you look at the raw numbers, one could still say if there's a prior history of cancer, one could be more comfortable with an IL-17 inhibitor or something like CD20.
I think but that's IL-17, and Robert, you know this because you cover the psoriatic world really well. You can't compare psoriatic safety to RA safety and IBD 100%. Safety. RA safety and IBD safety, very dirty. Lots, and maybe it's more chronic inflammation, hard to say, and hence they have much higher safety numbers as far as SIEs, hospitalizable events, and cancers and whatnot. And the psoriatic patients always their safety looks so much cleaner, so much nicer and friendlier. So I think it's just the population. So IL-17 is going to be a psoriatic population, right?
Exactly. No, that's exactly what I was alluding to. With number one, it's always the least, and the population's difference, kind of sometimes comparing apples to oranges here. And then also, like most of these trials or any sort of studies, there's no placebo group, right? And that's almost impossible. It's probably never going to be able to be done.
Yeah, it bears saying to the audience, and I've been following this issue since I was on the FDA advisory committee in 2003 and looked at all the safety data with biologics, that number one, if you've got a solid tumor, and that includes melanoma and skin cancer and lung, colon, brain, pancreas, you name it, any solid tumor, it doesn't matter. If they have a history of it, if they've got it right now, it doesn't matter. You treat them as you would treat them and do not care about the solid tumor. The data is overwhelming, absolutely overwhelming. If you want to scare yourself, then worry about lymphoma and TNF inhibitor use. I think that's silly and stupid because the data is overwhelming that yeah, you get events, but the cancer risk in all these patients is driven by inflammation. Patients
Exactly.
inflamed enough to get a biologic are, inflamed enough to get a cancer, and it's got nothing to do with it. This study was all about, it's a follow-up to the BSR-BR study, which raised everybody's eyebrows. So if you had a prior cancer, could you get another one again? And the answer was yes. And it didn't seem to matter unless they were talking about melanoma. It seemed like it might matter there. And what's happened since is that there's been no real good follow-up of that, although I think 11 registries, 9 countries in Europe got together and showed that biologics don't cause melanoma. That's pretty overwhelming. Doesn't really answer the question, if you had melanoma, might you get it again? But again, these numbers and these events are really quite low. And I think that these numbers are bigger in magnitude, if you will, as far as the total numbers, 352 and 9% getting cancer, is bigger than what was seen in the BSR-BR, but it doesn't change the story very much. Richard, do you have an opinion about this data?
Yeah, no, I think you kind of hit the nail on the head, Jack. I think the big risk in these patients is inflammation, disease activity, uncontrolled disease. That's what's going to drive your cancer risk a lot more than these biologic agents. And avoiding treating patients properly because of fear of cancer is probably doing them a disservice and probably increasing the risk of cancer.
Yeah. And so the sad part about this data, and Robert, you heard it because you watched this as I did, is that you want to know, did they get the same cancer again? And the problem is, when they started this Spanish registry, they only classified the patients as having either a lymphoproliferative or a non-lymphoproliferative, meaning solid cancer and skin cancer. And so when they have great data about the recurrent, what they call incident cancers, they had one melanoma and a few of this and a few of that, but they really don't know if this is recurrent, because at the level they had their data, they could just say it went from a non-lymphoproliferative to another non-lymphoproliferative. So doesn't give you that how likely you were to get a repeat tumor. And of course, that's probably the best data we'd like to see in a most ideal world. But if you've got one cancer and you get chemo for it, your chance of getting another cancer also are higher. So it's probably not that critical, but it is a gap in this particular data, and it may get more clear when they do the actual write-up. So we'll see.
Yeah.
Richard, what did you have that you like?
I think let's just stick with safety first. I came across 2 posters on the oral surveillance data, which are 519, 520. One of those by Karpouzis, the other one by John Giles. And I don't know if we knew this already, or I might have just missed it in the whole oral surveillance storm, but these are looking at kind of risk factors for the adverse events that were reported in oral surveillance. So the first one was looking at disease activity as measured by CDAI. And while there wasn't a statistically significant difference, there seemed to be a numerical increase in both MACE, in venous thromboembolic disease, and in infections in patients who had higher disease activity during the study. The second study was looking at statin use. And this was really surprising to me. So it looked at baseline statin use in oral surveillance. If you remember, oral surveillance was a high risk population. So it was bringing in people at high risk of cardiovascular disease. I think they probably generally be on statins, but actually only 23% of them were on statins at baseline. And there seemed to be, again, not statistically significant, but there seemed to be some association with being on a statin and having less cardiovascular risk during the study. So kind of what this said to me, oral surveillance, there's a small increase in risk there. It's put everybody in great fear of the JAK inhibitors, but actually we might be much better off focusing our time on properly controlling disease, on properly managing other cardiovascular risk factors in this population, rather than obsessing over which biologic we're using.
Yeah, it's that. So there's 2 different stories there. The easy story is the statin one, where too few of these patients who are at high risk, who should have been on statin, were actually on statin. And that's the slap on the wrist to rheumatologists. And that message has been out there very well. I think it's a little, I'll say humorous, but I really mean that sarcastically when I say rheumatologists will use comorbidity data to scare patients into taking drugs that they may be reluctant to take. But then how good are we at managing the comorbidities? Not quite as good. We tend to think it's going to be done by the primary care. spoke to a doctor today who's here in Denmark, and their patients really do have to see the primary care. In fact, they see their primary care much more than they see their rheumatologist. In the United States, that's not true. They think Dr. Chow is the smartest, bestest, most wonderful doctor they've ever had. And why would I go to someone who's not nearly as good as Dr. Chow? So they all have a primary care, they just don't go to them. So there is this comorbidity management gap that's a problem. How's it handled in Ireland?
Yeah, it's difficult. In Ireland, we don't really have a strict way of doing it. Some people will be managed by their rheumatologist, some people will be managed by their primary care physician. And for certain patients, they'll have a better relationship with their rheumatologist. Others will have a better relationship with primary care, which is actually probably an even bigger problem than anywhere else, because then there's no real sense of who should be owning it. So everyone being very busy can have a tendency to leave it to the other person.
Yeah, a little bit of cross-pointing. Robert, do you have a magical way of ensuring your patients getting good primary care management or comorbidity management?
Yeah, I mean, I think, this, for primary care question, I don't think I have a magic answer to that. But I think, this study or these studies really kind of echoed what we just talked about earlier with cancer. It's treating the underlying inflammation and underlying disease. And if that's not properly treated and the numbers show such, then of course we're going to have, issues, especially I think with the statin management and such. No, my recommendations to patients is, what I say is your primary care is your quarterback, right? And we're all sort of consultants in the team for certain things. They may be more, sort of adept to managing, especially, making sure, because sometimes patients come in, you have a complicated patient, and the statin, the cholesterol, even though it's important, is number 6 on the list, right? And I can see how that can sometimes get missed over and over.
Yeah, my way of managing it over the years has been, and I've worked in academic centers where it's easy and there's note sharing between you and primary care, and you can see primary care being involved, but most of us don't work in academic centers and there is no real note sharing. And so I make the patient the pigeon. I print out a copy of my note when I finish it, and I say, now you bring this to Dr. Strauss and make sure that he sees this. And he'll love you for bringing it to him. So that's my way of communicating with the primary care and making sure that my problem list, including the need for vaccination or whatever, gets handled. That was somewhat effective, certainly better than doing nothing, but this still is a significant gap. I do want to get to the issue of the inflammation and what you brought up with the first study by George Karpoussis, where he looked at the influence of inflammation in this trial. Remember, people going into this 1133 oral surveillance study had to have high risk factors, but they had high disease activity. They had a CDAI score greater than 40 going in, and the drugs were very good at improving clinical activity. So Karpoussis looked at whether they went from high activity down to moderate activity or to low activity or to remission. And if you really look at it, your first look, it looks like activity didn't matter very much. The problem, the truth is that it matters at a little bit more than a little bit, or not at all. It mattered the most in VTE risk. And I think you have to see sort of the graphic representations of this to get this message. It really did. And we know VTE is driven by a lot of things, including disease activity, inflammation. It mattered next most, and marginally, but significantly so, in MACE risk. It didn't seem to matter very much in cancer risk. And if it did, it was more for the TNF inhibitors than for the JAK inhibitors. So yeah, control of inflammation is important, but in this study, and everyone, we're all aware of the warnings for MACE and cancer, but in fact, there were more people who died from serious infectious events in this study than from those other two when you stack them up head to head. And so I think that's, still something we have to deal with while being worried about those 3 major things. I do want to, one of the things that came from John Giles, sitting next to him, we were discussing this, and he said something I thought was brilliant. We should be asking 3 questions if you want to start at JAK. Have you had a prior MI? Do you have a high cardiovascular risk? calculations. And number three, have you had a prior VTE? And that's how you know whether to go forward with a JAK or not. And I think that makes a lot of sense. All right, I want to stick with safety and talk about lupus and flares. There was a nice abstract, OP0143, that basically showed in a cohort of almost 200 lupus patients, the relationship between having either a minor infection, cold, sniffle, UTI, URI, or a major infection, something that led to hospitalization or morbid mortal risk. And they followed these patients over, I think, a 6-year period. And they basically showed the rates of infections, but most importantly showed, and the rates of like major infections was like 5 per 100 patient years, minor infections, 63 per 100 patient years. Lupus flare rates were 3.6 per 100 patient years for a major flare. And obviously a lot more for minor flares measured by SLEDAI. But they showed that if you had a major infection, you had a 7-fold higher risk of a major flare. Overall, any infection led to almost a 2-fold risk of a lupus flare. And, this is something we see, your RA patient who's well controlled gets the flu and they have some kind of flare. Was it influenza, arthralgia, myalgia, or was it really a disease flare? You didn't get to examine the joint, but it makes sense. It's the same cytokines, and whatnot. But this is sort of, I think, is a big eye opener to me, at least as far as how prevalent this was.
Yeah, I agree. I think one of the sort of silver linings of this COVID pandemic is patients are much more prone or accepting of vaccinations. So especially my new lupus patient, lupus nephritis patients getting CellCept or starting CellCept, I say please get your shingles vaccines, pneumonia vaccines, all lined up as much as you can. Obviously I know time is of the essence in these patients, because I think we've all seen more than enough lupus, shingles or zoster outbreaks. In just a few weeks ago, I had a patient with ophthalmic zoster and who fortunately did not get the vaccine. So people are so used to vaccines now and 2-3 boosters. Who knows how many more boosters we're going to get? And so I think a shingles vaccine, in the grand scheme of things, patients are much more accepting, and hopefully we prevent, because we know once a patient has a nasty infection, they get hospitalized. Yes, they could have a legitimate flare or not. And in most time, when they go to, let's say they go to hospital who are not so adept with rheumatology, then medicines get held, and then we can see how the flares can happen for sure.
Richard,
it makes biologic sense that this is that your immune system is stimulated to fight infection. There's going to be a spillover into the part that's gone wrong in your rheumatic disease, whether it's SLE or rheumatoid or whatever else. I think we've seen as well during the pandemic, because we haven't had any viruses as such because everyone's been masking, that the rates of these infection stimulated flares have probably been lower, and patients have certainly remarked that way to me. But I was a bit pessimistic about it. I'm not sure anything's going to change in the long run. We're already coming out of the pandemic mindset and people are going back to their usual behaviors, including our patients.
Including our rheumatologists. I'd say I'm part of a strong minority of people wearing a mask at this meeting. And I'm wearing it because I need to test positive to get back in the United States. I don't want to chance that in any way, shape, or form, but I'd say 85% or more not wearing masks at this meeting. Maybe one of the things that did happen as positive out of the pandemic is the ones who did believe in and use the COVID vaccines are, as Robert said, are more likely to get the other ones. But I think that actually has trained the rheumatologists to be better at giving the vaccines. I did a paper many years ago with Jeff Curtis showing that, again, rheum's not very good at using statins, not very good at getting vaccinations done. And there's, that data's out there, but maybe with enough of us, really harping on the COVID, we're getting better also at now the other things we should be doing. So let's do a quicker round, one last abstract from each of us. I'll start with the proof study. Dennis Badubny looked at a cohort of 562 patients with non-radiographic axial SPA and followed them 5 years to see how many were going to progress. And in that study, I think the number was 16% progressed at a mean of 2.4 years. And the predictors of progression were fulfilling males, B27 positive, fulfilling the imaging criteria of ASAS, and a good response to nonsteroidals for the patients who were actually going to progress. And this is, he's putting a number on something that's vaguely run from, I think, 10 to 40% and whatever. And so his was a prospective study. I find this interesting because I never thought I had any non-radiographic axial SPA, and I went to several meetings about it and kept saying never seen them, never seen them. And then I went back home and I saw like 2 the next day. And now that I know what it looks like, I'm making that diagnosis. But here's a number that you can point to.
Yeah.
Richard, you have one?
Yeah, so I've been tweeting a bit at the meeting, and what's surprising me, I had one tweet that got a enormous amount of attention, a lot more than anything else, and that was a study by Pujakana in gout, looking at transdermal sodium bicarbonate to treat gout flares. It's like madness, but so they've got 60 patients with gout, had them ready when a flare happened, gave all of them colchicine, and then gave half of them this transdermal gel of sodium bicarbonate to rub onto the affected joint. And shockingly, it seemed to have a huge effect. So complete response within 7 days of 95% versus 79%. Time to response of 24 hours for those with the sodium bicarbonate, 72 hours with just colchicine, and rescue meds in 6% versus 20%. So I don't know why it works.
Yeah, why?
The hypothesis is, or their hypothesis, which I don't really believe, but what they said is that the sodium bicarbonate might be alkalizing the joint fluid and making the crystals dissolve. But I can't see it getting in there, but that was the hypothesis that they gave.
So this bicarb gel was only put on the gout joint?
Only put on the gout joint.
And how do we know this isn't a placebo effect of rub your joints and get better?
Well, the placebo group also had a placebo lotion gel that they put on. I think what something Tuhina Nyoji said back to me on it was that what you really want to see now is somebody to go in and do a pre and post aspirate of the joint and see if this stuff actually does increase the pH in the joint. And you don't need to do it in people because you probably wouldn't be ethically allowed to do that. You can do it in animal studies.
Compelling. Crazy, but compelling.
To play devil's advocate here, I mean, baking soda is just sodium bicarb, right? So we could just have our patients put some baking soda in some water, rub it on the joint, see if it works.
That's the other thing, that this is a patented sodium bicarbonate gel of some sort. So probably a lot of money in it, but baking soda is very, very, very cheap. So maybe we can do that instead. Yeah.
Oh my goodness. Rheumatology is going back to the future. Robert, what's your last one?
My last one, as a father of an almost 1-year-old, focusing on pregnancies and of course our biologics. So this is OP0129, focusing on congenital malformations with intrauterine exposure to non-TNF inhibitors. And this really included a whole gamut, going from abatacept, anakinra, although we don't use it as much anymore, even belimumab. We have IL-17 inhibitors, CD20s, tocilizumab, IL-1223s, and vedolizumab. They did not find a signal for most of them, but they did find that vedolizumab, ironically, or incidentally, even though we don't use it as much, obviously, they did find a specific congenital malformation pattern, something called corpus callosum agenesis. Obviously, that's a little more.
What's the drug again? Natalizumab?
Vedolizumab. Entyvio, I believe.
GI drug.
Yeah, the GI drug. We probably don't use it as at all.
The integrin inhibitor.
Right. But they did find that belimumab potentially were associated with higher congenital malformations. The others, not so much, but the take-home message is that the vedolizumab at least had some specific congenital malformations. So I think the still take-home message is healthy mom, healthy baby.
You know, absolutely, that can't be said enough.
Yeah.
But proving congenital malformations is very difficult because in the normal population, general population, the congenital malformation risk is 3 to 6%. Usually in any kind of study that's done on the risk of congenital, defects and whatnot, done prospectively, doesn't have a large enough N or a large enough comparator group to really know what the effect is. So what was their comparator group, and were there numbers in the thousands here? Was this claims data?
Yeah, no, I don't think there was like a placebo, sort of a general normal population. I mean, they had actually, it was like 95 total patients on biologics in summary. So, these were very, very small.
To know, but
yeah.
We in rheumatology worry about congenital malformations. Our most teratogenic drug is mycophenolate. Can't be said enough.
Yeah.
Everyone thinks it's methotrexate. Sorry, people. Not a lot, but a few reports in the literature of patients taking methotrexate and leflunomide and having healthy babies with no risk of malformations. I'm not recommending that, but the one that's really most teratogenic is mycophenolate, and that bears repeating. I find most of the malformation data that's come out to be encouraging. So like you, Robert, I'm, healthy mom, healthy baby. I'm going to treat the mom to the max so that she's not inflamed and can deliver a normal baby. So, all right, guys, thanks so much for your time and sharing this great information. I want to remind the audience that we're going to do this again tomorrow night. We're going to live stream at, let's see, that's going to be 1 p.m. Eastern time and live stream to our website, Room Now, but also to YouTube, Twitter, Facebook, and LinkedIn if you want to watch in on any of those channels. Again, we'll just recap day 3 from EULAR. Folks, have a great night.